Is that okay? Okay, so first of all, I want to thank the organizers of the Pediatric Update virtual conference in Cairo for allowing me to do this presentation this morning here in Canada. I know it's evening time for you in Cairo. And I wish I could visit your country maybe next year, I don't know, when all this craziness is over. So to start, I have no conflict of interest to declare. The objective of my presentation today will be to identify basic principles of how to ventilate newborn infants. Second, to describe the different type of conventional ventilators. And finally, to describe measurements to be taken to prevent lung injury in these newborn infants. As you know, there has been, let me see if I can change there you are. There have been significant new strategies to treat and prevent respiratory stress syndrome that has significantly improved the mortality and have decreased the incidence of and severity of complications related to RDS in premature infants. However, bronchopulmonary dysplasia, BPD, continues to be one of the most common complications of RDS. And actually, the incidence of BPD has not only changed over the last 15, 20 years, but it's been a slight increase in the incidence of BPD over this time. So I think if we want to make a difference on bronchopulmonary dysplasia, we need to start changing our approach at the delivery with these infants. So for many, many years, especially those of us that are a bit older, 34 years ago, our approach in the delivery room of these infants, what I will call a reactive care or the firefighter approach. And this approach basically was one that reacted to emergencies, wait for things to happen, destroy things in the way, we didn't have time for patient. Nowadays, what we need to do and what we try to do is change our approach to what we call a preventive care or a gardener approach. This type of approach is characterized by trying to prevent the problems, not just to react to the problems, to try to anticipate things, to create a nurturing environment, and finally to have a lot of patience. So if we need to summarize the reactive care or firefighter approach, is interventional and invasive. And if you want to characterize the gardener approach, is observational and gentle. So how do we move from this interventional to non-invasive approach in the delivery room? So one of the first things we need to do is, first of all, be sure that we limit the excess of oxygen. Just adjust the oxygen as the saturation, the pre-ductal saturation information we get from the patient. We don't start with 100%, and we don't automatically increase the oxygen just because the baby is not pink enough. So always adjust the FL2 according to the SATs that we obtain from the pre-ductal sample. Second, if you're gonna use PPV, be sure that you limit the inflating pressure and you always have a pressure gauge that is monitoring how much pressure you are delivering to those lungs. Third, always try to use very early non-invasive ventilation. The early introduction of CPAP as soon as the baby is born is crucial to establish an early FRC and lung volume in these infants. And finally, if you think the baby needs surfactant, well, what we try to do now is try to prevent intubation to give surfactant and use what we call the minimal invasive surfactant treatment, in which we use a small catheter through the trachea to give the surfactant and avoid giving positive pressure ventilation due to surfactant administration. So we know that there is a strong association between the development of bronchopulmonary dysplasia and mechanical ventilation. And mechanical ventilation can damage the lungs by several mechanisms. We can have volutrauma from excess volume. We can have barotrauma for excess pressure. We can also have atelectotrauma if we don't use enough PEEP and we lose lung volume. We know that the not using proper temperature and humidification of the gas can cause also damage to the lungs. As soon as we put in the tracheal tube, we can cause trauma and we increase the risk of infection. So all this will contribute to the development of lung injury and bronchopulmonary dysplasia. So strategies that allow us to minimize lung injury has to try to prevent intubation and mechanical ventilation. So because of this, there has been a switch to less invasive form of respiratory support to avoid these adverse effects of mechanical ventilation. And one of those approach has been the use of very early CPAP in the delivery room as a lung protective strategy that should start immediately after birth. Now, how does the CPAP work? There are many, many mechanisms by which CPAP, nasal CPAP can help you with your care. First of all, we know that CPAP develops and help us to develop an effective FRC. Also, we know that reduces atelectal trauma, improve oxygenation, decrease airway resistance, help us to split the chest wall and airway, improve surfactant metabolism, prevent intrapulmonary shunts, decrease work of breathing, and finally, we know that nasal CPAP promotes regular breathing. Now, what's the problem with CPAP? Well, this is a study that was done by Dr. Morley in Australia, that randomized babies to either receive prophylactic intubation and surfactant versus just prophylactic nasal CPAP. And although the CPAP group did as good as the intubation group or better, this is what they found. 55% of babies between 25 and 26 weeks failed initial nasal CPAP and needed to be intubated. And even 40% of babies between 27 and 28 weeks also fail nasal CPAP and need to be intubated. So definitely we cannot get away with mechanical ventilation yet. So how do we ventilate these infants? Well, about 34 years ago, we only had one ventilator, and that was used for any kind of lung pathology and all type of babies. Nowadays, thanks to the technology, we have many different type of ventilators, and we know now that not all the lung pathologies can be ventilated equally. We need to pick the ventilator that is best for that lung pathology. And also we know that lung pathologies are not static. They change quite a bit, and sometimes they change quite fast, especially when you give surfactant to these babies. And within hours, sometimes minutes, the lung pathology can change. And we need to be ready to adjust our mode of ventilation to that change in lung pathology. And finally, as I say several times during my topic, the default is not intubation, the default is extubation. So as soon as you intubate a baby, work towards an appropriate extubation. Now, having said all this, there are some basic principles of mechanical ventilation that could be applied to almost any lung pathology and any ventilator you want to use. And those are these four. First, we need to achieve uniform lung inflation. That's regardless of the lung pathology you're dealing with and regardless of the type of ventilator you're using. Second, minimize over and under inflation. Third, minimize FiO2. Excess oxygen, oxygen toxicity is one of the most important aspects on lung injury. And finally, as I said before, always aim for an early appropriate extubation. So what are the benefits of keeping the lung open? We know that trying to keep the lung open produces a more homogeneous distribution of gas, decreases regional atelectasis, optimize ventilation perfusion match, reduce intrapulmonary shunts, and also decrease pulmonary vascular resistance. And finally, allow us, when we open the lungs and we decrease atelectasis, allow us to use less oxygen for our babies. So this is an example of the type of injury that you can get when we put a baby on a ventilator. Here we have, on the bottom, we have the atelectal trauma zone or atelectasis. And on the top, we have the volume trauma zone or overdistension. And here is our safe window in the middle. So we should be ventilating in this area only, avoiding the top part and the lower part. So when we use high tidal volumes and low PEEP, we can get both injuries. We can get atelectotraumas and we can get volume trauma. However, we can also get volume trauma if we use normal VTs. If your PEEP is too high, you could end up with volume trauma, just even using normal tidal volume. Also, even if you use normal tidal volume, you can get atelectotrauma because you're not using enough PEEP. So the idea is to use normal tidal volumes and adequate PEEP to maintain those lungs open and avoid those two areas of injury. So use adequate PEEP to maintain FRC and avoid atelectotrauma, and use adequate tidal volume to avoid volume trauma. So how do the ventilators work? Now, these machines are very simple. Just imagine you have a T-piece, okay? So here's a T-piece, okay? So here we have the flow of air, okay? A flow generator that inject air into this circuit, okay? That's continuous flow. And then at the other end, we have an expiratory valve that will open and close according to a time cycle time. So when the inspiratory time that you set is over, this expiratory valve will open and the air, instead of going into the patient, will go out, okay? And that will begins the expiration. So when this flow generator inject air into the baby's lungs, when this valve is closed, it depends what type of ventilator we are using. If you're using pressure limited, this flow generator will inject this air into the lungs until that pressure that you set is achieved. And then when that is achieved, then the flow will stop and will keep that pressure, that amount of air generating that pressure inside the lungs for the time that you set your inspiratory time, okay? And you can see that you're ventilating with pressure because when you look at the flow waveform, you will see this flow waveform has a sinusoidal shape. If you're using a volume ventilator, now the ventilator will infuse this flow into the lungs until the flow that you set is achieved. And that when that flow is achieved, the flow will terminate until the inspiratory time that you set is done, and then the valve will open. So when you look at the flow waveform on volume ventilation, you will see the flow waveform is square because that's the determining factor, okay? So you can divide the type of conventional ventilators according to the type of control you're using, as we just explained. The first one is controlled by pressure. The second one is the one controlled by volume. And the one that we are using nowadays, especially here in North America, and I would say in most units here in Canada, is what we call the combined or hybrid, okay? That uses a combination of both pressure and volume. So there's advantages and disadvantages of both type of controls. When you use a pressure ventilator, the advantages are that it maintains a stable peak inspiratory pressure throughout the inspiration. Second, you have a more physiologic flow curve or sinusoidal flow curve. The disadvantages of the pressure ventilator is that if you have sudden changes in compliance, your tidal volume will change. So if your compliance gets worse, significantly worse, now all of a sudden you're gonna get, with the same pressure, you're gonna get significantly less volume. If all of a sudden you give surfactant and your compliance improves significantly, with the same pressure, you're gonna deliver significantly higher tidal volume and you're gonna cause volume trauma. So you need to adjust your pressure almost continuously as the compliance changes. Okay? Otherwise, you're gonna definitely have problem with excessive tidal volume or lack of tidal volume. As I said, high risk for volume trauma. And because of this, it could lead to either hypoventilation or to alveolar distension if your compliance changes significantly. Now, when you use a volume ventilator, by the way, these ventilators are not available in the newborn. They're only available in adults. The advantages of the volume ventilator is that the VT, the tidal volume, is constant and is independent of changes in compliance. So what changes here in the volume ventilator is the pressure. So if your compliance gets better, you're still delivering the same volume, but all of a sudden your pressures are going to go down. Okay. If your compliance gets worse, you're still delivering your pressure, your volume. Now your pressure, your peak pressure you're measuring is going to be much, much higher. Okay. So it's an auto winning as compliance improves. So you don't need to worry about winning anything. As the lungs get better, you're still delivering the same volume, and the pressure will start going down on its own as the compliance gets better. Now, there is some disadvantages of volume ventilator. The first one is that the peaks of high pressures could lead to barotrauma. Although volume trauma is more injurious to the lungs than pressure, definitely high pressure can also cause injury. So if your compliance is very low and you're trying to deliver a physiologic volume, you could be exposing those lungs to very high pressures. And the only problem with volume ventilator is that your flow curve, as explained before, is square and produces a higher PIP for the same VT than the pressure mode. Now, what are the hybrid modes? These are ventilators, new ventilators that combine pressure and volume. In neonates, these ventilators are pressure control. Okay? Just to clarify, they are not volume control, they are pressure control. One of the things that their residents and fellows are confused all the time. They think because we use volume guarantee or volume targeted ventilation, they think these ventilators are volume control. They're not, they're pressure control, okay? But the way they work is that the ventilator will measure continuously the expiratory tidal volume, and it will adjust the pressure to try to target or aim for that volume that you set, okay? So the peak pressure or inspiratory time is automatically adjusted to ensure a predetermined volume. So this is the way it works. So here we have the first breath with an X pressure, whatever, that delivers a desired tidal volume. This is our desired tidal volume that we set. Usually it's about 4.5 to 5 per kg, okay? So in the first breath, this PIP will give us our desired tidal volume. So the ventilator, the next breath will be the same. We'll use the same pressure, okay? But now, with this pressure, for whatever reason, the tidal volume now is less than before, and has not achieved that desired tidal volume. So the ventilator will say, okay, we need more pressure here because this volume is not high enough. So the next pressure, the ventilator will deliver a higher PIP, okay? Now with this extra or excess PIP, now the volume is achieved again. So the next breath will be the same, using the same PIP. But now with this PIP, the tidal volume is going to be higher than the desired tidal volume. So the machine will again adjust that PIP and will bring it back down to see if that will give you the desired tidal volume. And that's the way the ventilator works, with breath by breath. Keep adjusting the PIP, try to achieve the volume that you set on the ventilator. Okay, so the other way that ventilators are classified is by the type of breathing that you are using. So it could be non-synchronized or synchronized or triggered by the patient. The non-synchronized ventilators they're available, but hopefully nobody's using them anymore. Those are the ventilators that we used 30, 40 years ago, the only ventilators that we had. And those are the intermittent mandatory ventilators. This ventilator had a fixed frequency that you set and a fixed TI that you set, okay? And we're completely independent of the patient's own respiratory efforts, okay? Now, the synchronized triggered by the patient are new machines that actually detect small changes in pressure or flow, depends what you're using, at the level of the ventricular tube. And the machine, the ventilator, will try to deliver that breath in coordination with the baby's own respiratory efforts. There is a big advantage on that. As you know, during spontaneous breathing, the air is suction into the lungs. During positive pressure ventilator, the air is pushed into the lung, which is not physiologic. So if you can somehow create a negative pressure by the spontaneous breathing of the baby, you can cause less trauma when the air goes into the lungs. So this synchronized triggered by the patient can be divided into SIMV or synchronized IMV, in which the frequency is fixed, it's set by the operator, and also the TI is fixed, it's set by the operator. Then we have the assist control, in which the frequency is variable. The frequency is set by the patient, okay? And the machine will support every single breath the baby takes. But again, same as SIMB and same as IMV, the TI, the inspiratory time, is fixed. And then we have another form, which is called PSV, which is the only fully synchronized mode of ventilation. As you can see, all these two on the top, the SIMB and the AC, only synchronized during inspiration, but the expiratory phase is not synchronized at all. With PSV, the idea is you try to synchronize both inspiration and expiration. So the frequency is variable as we use with AC and is set by the patient, but now the TI is also set by the patient and is variable, okay? So these forms here, the first three, IMB, SIMB, and AC, I cycle by time, as I explained before, and is related to the TI, the inspiratory time that you set. However, in the last mode, because the TI is variable, this ventilator is cycled by flow. So ventilator actually will measure the flow, and it will terminate inspiration when the flow wave start dropping. And you can actually set the sensitivity of that by say 20% or 30% or 40% of the drop in the initial flow to initiate expiration. So this is an example of synchronized ventilation on SIMB. So here we have, in green, we have the spontaneous breath by the patient, and in pink, you have the breath that are supported by the ventilator. As you can see, during SIMB, you only have a set of frequency that you set, usually 30, 40, 50 per minute. So if you set a frequency of 30, the machine will deliver a breath every 2 seconds, okay? And it will try to match that breath with a synchronized breath triggered by the patient, okay? So you can see in this mode, you have breath that are completely spontaneous, that are not supported by the machine, like in green here, negative, positive, but then you have breath that are fully supported by the machine. As you can see, this creates a pattern that is not homogeneous, okay? So the SIMB only support presets frequencies, allows spontaneous breath without support among ventilatory breath, has a potential to increase work of breathing, and produces a synchrony between the patient and the ventilator. So this is a mode that here, at least in Winnipeg, we don't use anymore. We haven't used SIMB for, I would say, 30 years, because we don't think this is the best way to ventilate a patient, okay? We think the best way to ventilate a patient is try to support every single breath. And that's what we use when we use the assist control ventilation. And in this mode, as you can see here, every single breath the baby takes is supported by the machine, okay? And again, it's always synchronized your inspiration. As soon as the baby takes an inspiratory effort, the machine will deliver the supported and breath. Now, the problem with this mode is if you have a baby that is agitated and is breathing very, very fast, 100, 120, you could end up with an inadvertent PEEP because your expiratory time is going to be too short, okay? If your inspiratory time is too long and the baby is breathing 100, 120 times per minute, your expiratory time could be too short, and then you could end up with inadvertent PEEP. So you need to be aware of that, and there are ways to do that. Now, there are many reasons why a baby would be breathing so fast, maybe because you're not supporting each breath very effectively. Maybe you're not using the right tidal volume, and the baby needs more support. And in that case, you may actually need to either increase the tidal volume, maybe changing the PEEP, or maybe changing the TI, okay? So the synchronized AC is characterized because every breath is assisted by the ventilator. You can wean off the ventilator by decreasing the frequency because it's not set, it's set by the patient. There is less risk for asynchrony between the patient and the ventilator compared to SIMB. And as I said before, it can produce hyperventilation and air trapping if the baby is quite agitated, because the ventilator will support every single breath the baby takes. Now, the other form that I mentioned before is the PSV, which is the flow cycle ventilator. And in this form, in this mode, the patient controls the frequency and the inspiratory time through a variable flow. The patient determines not only the beginning of the breath, like SIMB and assist control, but also the termination for each breath. So it's the only fully synchronized mode of ventilation, okay? So complete synchronization, inspiratory and expiratory between the patient and the ventilator. And because of this, it has the potential to significantly decrease the work of breathing compared to the other modes. So what are the things that we can do to prevent lung injury? Well, one of the things that you need to be aware that you need to try to prevent is overdistension, okay? So overdistension, as I mentioned before, or excess volume is more important than too much pressure. Very high pressures have little adverse effect if overdistension is prevented. And the next question is, how do we determine overdistension? How do we know if we are actually overdistending the lungs? Well, we have different things that we can use to know if we are overdistending the lungs. First one is a chest X-ray. Looking at the chest X-ray, look at how many reps you have of lung expansion, looking at the shape of the diaphragm, look at the shape of the heart to see if you're compressing the heart, will give you a good idea if you are overdistending. But that usually only detect significant overdistension. The next one is, of course, a blood gas. If you're using too much volume, at the beginning, you can get hyperventilation and low CO2s. But if your overventilation is significant, you could end up with significant air trapping, increased dead space, and actually your CO2 will start going up. Okay? Finally, which I think is more accurate and precise, and will give you an idea sooner than when you get significant overdistension, is the use of pulmonary graphics. Okay, so to reduce overdistension, always prevent tidal volume from being too high. So if you use only volume guarantee, you are going to significantly decrease the risk of overdistension. Second, try to prevent end expiratory lung volume from being too high. Okay. And third, prevent inspiratory time from being too long. So it's not only the volume, it's the PEEP that you're going to use, and also the inspiratory time that you're going to use. So this is an example of how to detect overdistension using the pulmonary graphics. This is the loop that we use to relay pressure here on the bottom, the horizontal axis, with volume in the vertical axis. And this is inspiration, this is expiration. Okay? As you can see, at the end of this curve, you see a beacon here. That means that the compliance at the end of this curve has changed. It's become worse, it's more flat. You need more pressure to produce less volume. So the ventilator, most of the new ventilator will actually measure the relationship between the compliance of the last 20% of this curve with the total compliance of this curve. And that's called C20 over C dynamic, okay? Now, normally, if you don't have overdistension, if you don't have this beacon, the compliance of the last 20% should be very similar or equal to the total compliance of those lungs. In that case, the ratio will be close to 1. However, when you get overdistension and you get this significant beacon here, the compliance on this last 20% will be significantly lower than the total compliance of the lungs. So the ratio is going to come down. So every time you have a C20, C compliance less than 0.8, watch out, you may be having overdistension. So again, to reduce overdistension, always use physiologic tidal volume. And the physiologic tidal volume should be adjusted according to the size of the patient and the type of pathophysiology you are dealing with. In general, it goes from 4 to 5 mLs per kilo. We know that this volume guarantee works. There was a meta-analysis done by Wheeler in 2011 that showed that the use of volume guarantee decreased mortality, decreased bronchopulmonary dysplasia, decreased duration of ventilation, pneumothorax, hypocarbia, periventricular leukomalacia, severe IVH compared to babies that were ventilated with pressure-limited ventilation without volume guarantee. So we know that volume guarantee or volume targeted ventilation is much more physiologic and is associated with better outcomes than not using. So another way is to reduce overdistension is be sure that your PEEP, the PEEP that you're using, is not too high. So every time the FiO2, you're ventilating a baby and your FiO2 start going down, most likely your compliance is getting better, and most likely the PEEP you're using now needs to come down, okay? So try to reduce your PEEP as the FiO2 falls. And if that's correct, what you're doing is correct, you will see that the peak inspiratory pressure also will fall, okay? Remember, the PEEP pressure is the pressure that the machine needs to deliver the target volume. So if your lung volume is appropriate and your lung compliance is getting better, as you decrease the PEEP and you decrease overdistension, the PEEP should also start coming down. Volume should increase on if you're using pressure ventilation and you're not using volume target. As you decrease your PEEP, if you did the right move and your compliance is getting better, you will see that the volume that you are delivering with the same pressure also goes up. That means that you've done the right move, okay? And the other thing that you need to be aware that is avoid inadvertent PEEP. This is not the PEEP that you set, it's the PEEP actually that's delivered to the baby or the lungs are seen, okay? What's inadvertent PEEP? So, and that's you diagnose by looking at the flow waveform, okay? So in the waveform, we have anything that goes up is inspiration, everything that goes down in yellow here is expiration, okay? So the dotted line here is a normal expiratory flow that reaches baseline before the next breath, the next inspiratory flow begins. In this case here, you can see it could be for two reasons. It could be maybe because your expiratory resistance is too high and it takes longer for the air to leave the lungs, or maybe because the TE, the expiratory time, is too short and you're not allowing the flow to completely escape the lung before the next inspiration. But in any case, you can see here that the expiratory flow does not reach baseline before the next breath starts. So you end up with extra pressure here in the lungs before the next breath. That's called air trapping, and it's called auto PEEP. You may think your ventilator is baby with a PEEP of whatever, 6, 7, 8, but actually you may be with baby with a PEEP of 9, 10, or 11. Okay. So every time the expiratory flow does not return to baseline and inspiratory start before expiration ends, you could end up with air trapping. The other thing is to prevent adelectasis. As we said, try to avoid using high PEEPs, but also try to use adequate PEEP. I can't tell you what the right PEEP is because it depends on the patient, depends on lung pathology you're dealing with, and depends on the compliance. So in general, try to keep the FiO2 less than 40%. If your FiO2 is more than 40%, unless you have pulmonary hypertension, most likely you are not opening the lungs properly and you need higher FiO2 to compensate for the lack of mineral pressure, okay? And you remember that the mineral pressure is mostly set by PEEP. So this is an example of inadequate PEEP. Here we have, again, the pressure volume curve. As you can see here, this baby here, there is a flat part here in the beginning of this curve in which you need a lot of pressure to open up those lungs to get volume into the lungs. That means that your opening pressure is way above your set PEEP, okay? So this is telling you that the PEEP you're using is not high enough. So by adjusting the PEEP and trying to bring the PEEP to this point here, as you can see a smooth transition in the inspiratory limb of that curve that goes up straight, okay, without any style line appearance. So you can use this loop also to determine what will be the best PEEP for your patient. How do you determine the right inspiratory time? Again, for that, you look at the flow waveform, okay? So here we have an example of a TI that is too short with adequate expiratory time. As you can see here, the expiratory flow begins before the inspiratory flow reaches baseline, okay? By doing that, then you end up with a PEEP that has not achieved, okay? You end up with a lower PEEP that you set. In the middle here, we have an example of a normal TI with a normal T. Again, here the flow, inspiratory flow reaches baseline. There is a small plateau here. It's a small space, which is physiologic. And now you have a PEEP that has achieved the desired PEEP with almost no plateau. And then in the last example, I'm going to show you an example with a long TI and a short TE. Again, here you have the inspiratory flow that reaches baseline, but then you have a long pause here, okay, before the next inspiratory flow begins. So when you do that, then you end up with a prolonged plateau in your peak inspiratory pressure, okay? And because you do that and your TI is too long, then your TE becomes too short, okay? And that causes what we described before, air trapping, because now you don't have time to get rid of all the air from your lungs. The next inspiration starts before the expiratory flow reaches baseline, so you end up with auto PEEP. So prolonged inspiratory time will not give you an extra recruitment, will not give you extra volume into the lungs, will just increase your mineral pressure and may cause increased pulmonary vascular resistance, may also cause decreased pulmonary venous return to the heart, may also cause an abnormal return of the blood from the brain. So things that we can also do to improve ventilation and minimize lung injury is maintain the infant's spontaneous breathing. Again, minimize sedation. Try to use not use respiratory depressants. Try to use early caffeine to stimulate breathing, and avoid hypocapnia, because if your CO2 is too low, the baby is not going to breathe. And early extubation. Remove ventute as fast as appropriate, or not intubating if you can avoid it. Self-evident that never being ventilated is better than being ventilated. And we can say for sure that BPD, at least severe BPD, does not occur if a baby is never intubated. And if you need surfactant, it's better to give it sooner. And ideally, as I said before, using a minimal invasive treatment. Okay? The challenge is to identify quickly infants who will need surfactant and try to treat those infants appropriately. Okay? So just to give you a brief example of more or less general parameters that we use for mechanical ventilation, try to use a low physiologic VT, usually between 4 or 5 mL per kilo. Again, depends on the size of the patient, depends on the pathology you're dealing with. Use moderate to adequate PEEP, 6 to 8, but again, use your pulmonary waveform to determine what will be the best one. Try to always aim for low pressures, 10 to 20. Use high frequencies, usually 4 to 60. Don't go higher than 60. No, don't go lower than 40. Use short, adequate TIs, and always look at your flow waveform to determine what will be the best TI for that patient. And always try to aim for low FiO2, as I said before, to avoid oxygen toxicity. Okay, so this is the last slide. I'm gonna give you a bundle that we use here in Winnipeg to try to minimize the risk of lung injury and BPD. So always try to use prenatal steroids. Use intrapartum antibiotic for prolonged premature rupture membranes. At delivery, always use prophylactic CPAP. The first thing you need to do in these babies, especially the small ones, is put the baby on nasal CPAP. Avoid bagging this baby with high pressures. Use always blended oxygen and guide your oxygen delivery by your preductal saturation. Try to always preserve spontaneous breathing. In the first 24 hours, use early rescue surfactant treatment, usually by MEST, minimal invasive surfactant treatment. Use early caffeine. Be careful when you look at your PEEP. Be sure that your PEEP is adequate. If you need to intubate, always use assist control and with volume guarantee, and usually use short TIs or appropriate TI guided by your flow waveform. Okay. Use permissive hypercapnia, and what I mean by this is not just to force the CO2 to go up, but allow the CO2 to be okay for when you have enough lung volume. Don't try to aim for a CO2 that is normal, 40, 45 when you have abnormal lungs. That's not physiologic. And finally, always try to do early extubation to either nasal CPAP or NIPPV if your center is familiar with that. And as we use here, if you have high frequency ventilation, and use that as an early rescue, especially in tiny babies, to prevent exposing those lungs to high pressures and high volumes. And thank you very much. I don't know if you have questions now or at the end.